Hello, everybody, and thank you for being with us tonight. Our presentation will last for approximately 1 hour and will be presented by urologist Dr. William Critchlow from Urology of St. Louis. Dr. Critchlow is a native of Cape Girardeau, Missouri, and attended St. Louis University for his undergraduate studies before getting his medical degree at the Missouri School of Medicine in Columbia. After finishing his medical degree, Dr. Critchlow completed his urologic surgery training at the Mayo Clinic in Phoenix, Arizona. So, Dr. Critchlow, I'll thank you so much for giving us your time this evening. I'll turn it over to you.
Hi, good evening, everybody. I think I've unmuted myself successfully, so if you can't hear me, somebody please let me know. I'm Dr. Critchlow. I practice here in St. Louis. I imagine most of you are also sweltering through the humidity here in St. Louis. So thanks for joining us tonight. I know it's given up an hour of your evening, but thanks for coming. Hopefully you learned something. We're going to be talking about BPH here. We'll talk first a little bit about the anatomy and physiology of the bladder and prostate, because I think it's important to understand a little bit about that so that when we talk about things that we can do about it, those make a little bit more sense. We'll talk about what BPH is, how it affects people, and then what we can do about it. BPH is one of the most common things that any urologist sees. So these are very common problems. And luckily we have a lot to offer. And we see it all the time. So if you're dealing with this, you're certainly not alone. And again, this is something that we manage for you. So what is the prostate? The prostate is a little gland that when we're younger helps out in reproduction. As we get older, it causes problems. We'll talk about what those problems are in a minute. Just very briefly about how urination works. It's obviously much more complicated than what I'm going to talk about tonight, but essentially your kidneys, which sit about halfway up your back, you got one on either, most people have one on either side. Kidneys make urine, so blood goes in, urine comes out. The kidneys filter out the blood. They're a little bit like colanders. Pasta goes in, what your body wants to get rid of, that filters down. The urine goes down through two tubes that drain out your kidneys called the ureters. Those ureters dump into the bladder. Your bladder stores your urine. It's a big muscle bag. So it's a type of muscle called smooth muscle. So it's not under your conscious control like your heart. You can't think about it and make your heart beat. You can't flex your heart. You also cannot consciously contract your bladder. What happens is your brain releases its control over your bladder, and then your bladder squeezes down. Just like your heart beats to pump blood out to parts of your body, your bladder essentially beats to force the urine out of you. It does that for most people with fairly high pressure. You pee right through your prostate. So your prostate is the first part of your urethra. And you can see that nicely here. The prostate makes most of the ejaculate. And prostates grow over time. It's important to remember that while larger prostates generally cause more problems, that's not always the case. So small prostates can cause big problems. Big prostates can cause big problems. And so this problem is fairly size independent, but in general, prostates grow as we get older and become tighter as we get older as well. So I mentioned earlier that prostates cause trouble as we get older. They can do that in a couple different ways. They can cause obstruction of the bladder, which is what we'll be talking about for the rest of the talk. They can also get infected, and that's called prostatitis. Prostatitis specifically means inflamed, although often that's caused by bacteria. And they can also get cancer, which is a whole another topic and not something that we'll be talking about tonight. So BPH stands for benign prostatic hyperplasia. This is overgrowth of the prostate. Synonyms for this are enlarged prostate, prostate trouble. LUTS, which is lower urinary tract symptoms, is the symptom complex from BPH, from an enlarged prostate. And generally symptoms come from obstruction of the bladder. If you remember back to that picture earlier, again, you pee right through your prostate. So as prostates get bigger and tighter, they can obstruct the flow of urine. A lot of people, when we're talking in the office, are concerned that as the urine stream is slowing down a little bit as we get older, that's somehow a symptom of prostate cancer, and that's not true. These are separate entities. Urinary difficulty and prostate cancer are not the same thing. Now, you can also have prostate cancer if you have BPH and vice versa, but BPH is not prostate cancer, and symptoms are generally different. Prostate cancer is usually identified through screening with PSA blood test and a prostate exam. BPH is more of a symptom complex. So again, this is a nice picture that demonstrates that in the normal state, bladder, again, big bag of muscle that contracts to force the urine out, empties itself through your prostate. Over time, this is a picture here on the right of a prostate that's gotten enlarged, and this is just a nice cartoon demonstrating a little bit visually what the problem is and why oftentimes stream becomes weaker. Guys sometimes don't empty out completely when they urinate, which means that you've got to pee more often. Sometimes that means waking up at night a couple times. Sometimes that means standing there at the toilet for 15 seconds before the flow gets started, hoping and praying that things are gonna get out. Again, we just talked about a lot of this. The primary symptoms of an obstructive prostate, when we talk about these LUTs, these lower urinary tract symptoms, there's really two main categories. Obstructive symptoms, and those are things like a weak stream, trouble getting the urine flow going. Sometimes it's start-stop. Sometimes guys block up completely and can't pee at all. Some guys are cathing themselves. Some guys are living with a catheter because this prostate problem is so significant that they can't get any drop of urine out. Those are obstructive symptoms. An obstructed bladder oftentimes will get a little bit irritable. So those sorts of symptoms are having to pee every hour. You should, and some people need some education on this, you should pee about every 3 or 4 hours. That's considered about normal. Even though maybe back in the day you could pee once or twice a day, that's not good for your bladder. So you should pee every 3 or 4 hours, roughly. But frequency, urgency, those are more bladder problems, generally in men caused by an obstructive prostate. Your bladder's having to work with high pressure to get the urine out. And again, that can cause the bladder to become a little frequent and a little urgent. All of these symptoms are from this bladder prostate complex. And in men with prostates, generally we treat the prostate pretty aggressively first because that for sure should relieve the obstructive symptoms, the weak stream, etc. And oftentimes as the bladder becomes unobstructed, those irritative bladder symptoms will get better on their own. This is the problem. Most men at some point in our lives will have these symptoms. And they're bothersome symptoms. There was a recent study that came out looking at guys on Medicare, and about 2/3 take medications for their bladder or prostate. So that's 2 out of 3 men over the age of 65 that are taking a medication for this problem. It is an incredibly common problem. And not only does it cause you standing there at the toilet for 3 minutes, but it can also cause trouble sleeping, which can interfere with daytime fatigue, energy levels, can interfere with happy wives or partners, can interfere with sexual dysfunction. And so this is a serious problem. And again, we have plenty that we can do to help. Again, over half of guys by age 60, 2/3 of guys on Medicare. If you get to the ripe old age of 85, 90% of guys have trouble with this problem. 200 years ago, guys weren't living to 85 or 90. So this wasn't as much of a problem. Prostates, again, just continue to grow as we get older. So when you come to the office, what sorts of things will your primary care doctor or your urologist do to, other than talking to you about this, to evaluate you? You should be having a digital rectal exam if you're over the age of 50 or 55. at least once a year. Sometimes we check PSA blood tests. That's a whole nother conversation, but generally between the ages of 55 and 70 or 75, every 1 or 2 years. We can actually objectively measure how well you're emptying out your bladder. We use a little handheld ultrasound. We have you pee, empty out your bladder as best as you can. And then we use a little handheld ultrasound over your bladder to make sure you're actually getting your bladder empty. You would think that you would know if you're not getting your bladder empty. You would also be surprised by the number of times I see a guy who comes into the office and thinks they're doing just fine, and we find a liter or two in their bladder, and that's not a good situation. So that little ultrasound over the bladder is a really good objective way to make sure that you're emptying out your bladder safely for your kidneys. We can actually objectively measure how fast the urine's coming out of you. We look at flow rates, and that can give us some data on how strong the stream is, rather than just asking you. Usually we'll have some questionnaires. That's not just busy work to keep you occupied in the waiting room while we're late for our appointments. These questionnaires are validated questionnaires, which means that the questionnaire has been the subject of research. And so we really do pay attention to these questionnaires that we have you fill out. And it's a way to track our outcomes too. A lot of the studies on medications, procedures, surgeries use these questionnaires like the IPSS, the prostate symptom score, or the AUA symptom index to track their outcomes and tell us how well we did. So usually that's part of coming to see a urologist. So what can do about this problem? There's a lot we can do. By the time guys see a urologist, generally, they've tried some of the dietary changes, fluid changes, especially for getting up overnight, which is the most bothersome thing for guys. We usually ask you to stop drinking any liquids for about 2 hours before you go to sleep. Sometimes that's a hard habit to break if you've been having a glass of wine every night for 40 years in bed. I get it, but changing your diet, getting a little bit more exercise, losing a little bit of weight, all these things can help this problem a little bit. Again, generally by the time you come see a urologist, guys have been trying that already. We have medications, we have surgeries. We'll talk about those. A lot of guys will take supplements for this problem. In general, my opinion on supplements is that if they were safe and effective, Pfizer would have copyrighted it, and you would need a prescription to get it. So Flomax, for example, I'm sure most people on this webinar are familiar with Flomax. We know the side effects from Flomax because the FDA has put it through trials with tens and hundreds of thousands of men. Supplements don't have that benefit. So they may do great things, they may do bad things. Sometimes supplements cause trouble. Just because they're over the counter doesn't mean they're all totally innocuous. All of these supplements that you will see at Walgreens, at GNC, they all have different fancy names: Super Beta Prostate, Prostamax. All those things have saw palmetto. Saw palmetto has been studied. It probably helps a little bit, probably not a lot. But if you look at the ingredients on any of those supplements, they will have saw palmetto and a couple other things to distinguish them from the one next to them on the shelf. So in general, I do not recommend any supplements for this problem for the reasons I stated. Do you have to do anything about this? Some people do. Sometimes this problem causes medical problems for people. And what I mean by that is some guys aren't emptying out their bladder safely, which sets them up for urinary tract infections. Some people are not emptying out their bladders so much so that they're backing pressure up to their kidneys. And every once in a while, we'll get called from the hospital with a guy who's in renal failure because he's got 6 liters in his bladder. That's the most I think I've ever seen. And so some people don't have the luxury of choosing from waiting or meds or surgery. Sometimes this becomes more of a problem. But for guys in whom you're emptying out okay, and it's just a symptom problem, watchful waiting is an option. That means we don't give you medications. We don't do procedures or surgeries on you. There's very little procedural risk to that. The risk, if we're just keeping an eye on things, is that your symptoms aren't going to get any better, probably. This problem generally does not get better over time. It either stays the same or gets worse. So symptoms may get worse. You may, if you don't follow up, fairly regularly, once a year at least, with a urologist, if you're having these symptoms, you may get to be that guy who goes into the emergency department, gets a catheter, and can't get off the catheter for the rest of their life. So you may have missed your opportunity to do a nice, easy thing by letting this problem get worse and worse and worse over time. The prostate continues to grow over time unless you're on a medication called finasteride. And so when I see a guy who's 65 whose prostate is a little bit enlarged, and we're not doing anything about it, I'm just kind of knowing that prostate's getting bigger over time, and you may lose the chance to have a nice, easy 10-minute procedure, and we may need to do more invasive procedures. So the downsides of watchful waiting are, again, symptoms probably aren't going to get better on their own, may not get worse, but may. And you may lose your chance to have a nice, easy thing done, and may require something more later on. Medications are extraordinarily common, like we talked about earlier. 2/3 of guys on Medicare take one or both of the medications that I'm going to mention. This and the next slide talk about the two overwhelmingly most common medications that are prescribed for this problem. Alpha blocker, the primary one we use is Flomax, tamsulosin. That is generic, that is cheap, that has been around for decades, and it's fairly effective for this problem. It basically relaxes the prostate. So if you think back to that picture we looked at earlier, bladder's a big bag of muscle, having to squeeze to get the urine out of you. You can again think back to your heart. Heart's a big bag of muscle squeezing the blood out of you. Flomax relaxes the pressure that your bladder has to squeeze through by opening up the prostate a little bit, similar to lowering your blood pressure if you've got heart disease. Lowering your blood pressure makes it easier on your heart. Flomax makes it easier on your bladder. Stream generally improves. Guys generally empty out a little bit better. And this is almost always the first medication we use for this problem. The primary side effects of Flomax, in about 20% of guys, it will cause retrograde ejaculation, meaning when you orgasm, no fluid comes out. That's not a medical problem. The fluid, the ejaculate goes back up into your bladder, you pee it out next time. But that impacts some guys' enjoyment of sex. So some guys don't like that side effect, and this isn't a great medication for those guys. The other thing that we generally warn people about is a little bit of lightheadedness, like when you stand up too fast or pop up from a chair. Worry about that a little bit more in older folks or folks on multiple blood pressure medications. If you were to stop the Flomax, both of these things would go away. But again, extremely common medication, generally fairly effective, fairly safe for people. The other medication that's commonly prescribed is called finasteride or dutasteride. This is a 5-alpha reductase inhibitor. Your prostate takes your testosterone, and there's an enzyme called 5-alpha reductase that converts the testosterone into something called dihydrotestosterone or DHT, which drives the prostate to grow. It also drives male pattern baldness. So finasteride is the exact same medication that's in Propecia and Proscar, which is the brand name for finasteride for the prostate. Finasteride, again, generic, been around for decades, considered very safe. It works by shrinking your prostate. It can take up to 6 months to do that. Finasteride decreases the chance of you ending up in the ER someday requiring a catheter, decreases the chance that we do a procedure on you. The downside of finasteride is sexual side effects. 5 to 10% of guys will have some decreased interest in sex, trouble with erections, taking longer to ejaculate or retrograde ejaculation. But finasteride is another very common medication prescribed for this problem. The other medication that's sometimes used is daily Cialis, tadalafil, in a lower dose than is commonly used for erections. The erection dose is 20 milligrams, about an hour or two before you want the effect. The BPH dose is 5 milligrams once a day, and that's FDA approved for both BPH and for erections. Cialis has recently gone generic within the last year, so generally fairly cheap now. So those are the three classes of medications that are used for this problem, and again, very, very common stuff. Procedures, we'll talk about the procedures from least invasive to most invasive. Resume is a procedure, did one today. Resume is a very common procedure. We have a little video about it on the next slide, but we do resume in the office, so there is no general anesthesia. We only use local anesthesia. We numb up the prostate like we're going to do a prostate biopsy with an ultrasound. We put numbing jelly in the urethra, let that sit for about 10 minutes, and then we do the treatment. So we numb up the prostate from the inside and the outside, if you want to think about it like that. The treatment itself takes maybe 5 minutes. There is a scope, you're awake. I use a monitor so you can see what I'm seeing. And let's watch this video about Resume, which will describe that a little bit more.
Resume uses the natural energy stored in water vapor or steam. Clinical studies support that Resume relieves BPH symptoms safely and effectively, eliminating the need for BPH medications, while also preserving sexual function. During each 9-second treatment, sterile water vapor is released throughout the targeted prostate tissue. When the steam contacts the tissue and turns back into water, all the stored energy is released, causing the cells to die. Over time, your body's natural healing response absorbs the dead cells, shrinking the prostate. With the extra tissue removed, the urethra opens, reducing BPH symptoms. Most patients begin to experience symptom relief as soon as 2 weeks, and maximum benefit may occur within 3 months.
So Resume is a very nice office-based procedure that does not require general anesthesia, which a lot of people are very excited about. And essentially, again, like you saw in the video, we steam the prostate. That causes it to shrivel up, open up the channel. We usually leave a catheter for a couple days and then take it out in the office. I generally see guys back at 1 month. And what most guys will tell me that a week or two ago, symptoms all of a sudden just went away. For that first week or two, there may be some blood, there may be some burning, there may be some urgency and frequency. Even though this is a nice quick outpatient procedure that takes 5 minutes, it's still a procedure. If we replaced your knee is not going to feel great the day after surgery. So for a couple of weeks, things may be a little bit irritable, but reliably, when I see people back at a month, they say about a week ago, everything just got great. People are generally very happy with Resume, as you can see here. The retreatment rates, a question I get often is, how long does this last? And we have 5-year data on this. The retreatment rate is less than 5% at 5 years. So in other words, do you need another surgery done for this problem within the next 5 years? The answer for 95% of people is no. I should mention the degree of improvement that medications give people. And again, we talk about this in terms of that AUA symptom score, which is the questionnaire that we usually make you fill out when you see us. Most people on that symptom score, when they're getting set up for a procedure, they're at somewhere around 20 to 30 or so. The degree of improvement that medications give people is about 5 points on that. So you may go from 20 to 15. The degree of improvement on Resume and the next procedure I'll mention, which is UroLift, is about 2 to 3 times that, so 10 to 15 points. So a lot of guys who I see are on the maximum, that they're already taking Flomax and finasteride. So these procedures, Resume and UroLift, will improve you 2 to 3 times more than the medications will. So that's the degree of improvement, and that's how long it lasts, at least. As we get longer and longer studies with this, it's certainly possible that Resume will have a 4% retreatment at 15 years. We just don't know that yet. UroLift is the other minimally invasive procedure that is often done. We also do not use general anesthesia for this. We at Urology of St. Louis do this usually at our outpatient surgery center. We use a little bit of IV sedation, similar to a colonoscopy. So not a general anesthesia breathing tube, but some IV sedation. This also takes about 10 minutes, and basically we staple the prostate open. So if you think back to those pictures, most prostates will grow from the left and the right. So you have a left lobe and a right lobe, and you're peeing right through the middle of that. Resume steams these lobes to make them shrivel up and open up. A UroLift uses implantable little titanium and nitinol sutures, basically staples, to push those lobes open. It does not remove or destroy or get rid of any tissue. It just moves it out of the way. I generally tell people it's like pulling the curtains back. The degree of improvement is similar. There's no studies comparing Resume to UroLift directly, but in the ancillary studies, the degree of improvement is similar. It's, again, about 2 to 3 times more than medications. This has a little bit higher of a retreatment rate, so a little less than 15% at 5 years. And again, that's a surgical retreatment rate. Green light, photovaporization of the prostate, a PVP, laser ablation, these are all the same thing. This is a procedure generally done in a hospital with general anesthesia. I'll show a video of this in a minute. To be frank, I'm not a huge fan of this. I don't offer it. A lot of my partners do, and they've had good outcomes with it. So if you've had a green light or are thinking about a green light, I don't think that's the worst thing in the world. I just personally haven't seen the outcomes that I would like to see. What I think it does is help with the obstructive symptoms for sure. It destroys tissue, it opens up the channel. In my experience, it worsens irritative symptoms. So that urgency, that frequency, that feeling like you've got to run to the bathroom every 15 minutes, what I've seen, that can get worse after green light, which I don't really see in the other procedures. But because it's such a common procedure, and again, a lot of my partners offer this and have been very happy with it. Here's a little video just describing, it's about a minute long, describing what the procedure is. This is a good option for people who are on blood thinners. The specific wavelength of the laser that's used for this penetrates into the tissue beyond what we can see. And so that coagulates little blood vessels that can bleed during these procedures. And I think, again, that's why some people get these irritative symptoms, is because this laser is penetrating deeper than what we can see. And sometimes that gets the bladder. And so that can irritate that muscle of the bladder. Again, that's my experience. A lot of people have other experience, but for me personally, I don't do this procedure. But you just systematically go around, shoot the laser that ablates the tissue. So there's no carving or cautery. It just vaporizes the tissue. And you just get a nice open channel with that. And it certainly does help with the obstructive symptoms. There's kind of no doubt about that. Opens up the channel that way. I think there are better options, which is why I don't offer this. But I certainly could be wrong about that. Now we'll talk about procedures that are generally done in a hospital with general anesthesia. TURP is the gold standard. That's been around for longer than anybody on this webinar has been alive. It's been around since the early 1920s. This is a roto-rooter. this is an incredibly common procedure. It's a good surgery. I still do TURPs for the right people. And again, this is the gold standard. A TURP is done in a hospital with general anesthesia. Scope goes in, and we use a hot wire loop and just carve open the channel. So we're carving out chunks of prostate until the channel is nice and open and the adenoma is treated. We push those up into the bladder, and then through the scope, we get those out of people. Most people stay overnight in the hospital one night. Some people who really aren't having much trouble with bleeding can go home the same day. Usually a catheter for a day or two or three or so. The surgical retreatment rate, listed as 5 to 6%. I think it's probably a little bit less than that. The risks of a TURP are permanent retrograde ejaculation. So again, no fluid coming out with orgasm. There's a reported rate of about 2 to 3% of worsening erections after a TURP, although I really haven't seen that. Like the other procedures, for the first couple weeks, as things are healing on the inside, some urgency, some frequency, some bleeding, all that's fairly normal. Nobody really does a simple prostatectomy anymore because we have holmium laser enucleation of the prostate. That's similar to a TURP, so general anesthesia done in the hospital, usually stay overnight. Some people go home the same day, usually stay one night. Catheter gets removed the day after surgery. HOLEP is the acronym for that. And that is the most definitive on the matter. If you think about your prostate like an orange, it's a good analogy for a prostate. The prostate has a capsule, which is like the rind of an orange, which is where most cancers show up. The prostate has the pulp, which is called adenoma. Adenoma just means overgrowth of a gland. So you can get a thyroid adenoma, you can get adenomas elsewhere. When the prostate overgrows, that's adenoma. And so again, a resume, we steam the adenoma, that shrivels it up. A urolift, we staple the adenoma open. A TURP, we start carving out chunks of that orange pulp and adenoma. A HOLEP, all done through the urethra, and we nucleate all of the adenoma at once. The retreatment rate on that is, in the more contemporary studies of people who do it often, is 0.5%. So it is extraordinarily uncommon to have another surgery done for BPH after a HOLEP. It's really primarily done for bigger prostates, so anything over 70, 80 grams or so. A normal prostate when we're in our 20s is probably 20 grams. Anything over 100 grams is getting pretty darn big. Anything over 70 or 80 grams or so, I think a HOLEP probably is the best surgery. Again, it removes all of the adenoma at once. The downsides of a HOLEP, there's no impact on erections like there can be with TURP. There's permanent retrograde ejaculation like there is with TURP. And temporary stress incontinence, so leaking when you sneeze, when you cough, when you lift a heavy box. That goes away in almost everybody. It can take a couple weeks or a couple months to go away with Kegel exercises. Resume and urolift have essentially no sexual dysfunction, no real risk of retrograde ejaculation, no real risk of erectile dysfunction. TURP and HOLEP, those have assumed permanent retrograde ejaculation and general anesthesia and the risks that are associated with being in the hospital. These are all covered. These are all FDA approved, covered by Medicare, covered by most insurances. Sometimes we do have to jump through some hoops and document certain things before your insurance will cover it, but it's generally not a problem to get these things covered. So the prostate, again, is a little gland, helps out in reproduction when we're younger, causes trouble for almost everybody as we get older. Urinary symptoms that we can attribute to the prostate, that's called BPH. Most people have the option of doing nothing about that if you can live with the symptoms, although again, there are risks to that. We usually start out with medications like tamsulosin, which is Flomax, finasteride, which is Proscar, although you do not have to start on medications first before getting a procedure, although most guys want to do that. We have minimally invasive procedures that are either office-based or outpatient surgery-based, like a Resume and a UroLift. We have more invasive, although all of these are done through the urethra, no incisions. We have more invasive, but probably longer lasting procedures like a TURP or a HOLEP or a green light. I offer Resume, UroLift, TURP, HOLEP, because I think there's no prostate I can't treat very effectively with one of those 4 options. I think that picking the right procedure for the right prostate is probably the most important thing, and having happy patients and really helping guys with this problem. Some people who only do UroLift, if everything looks, if all you've got is a hammer and everything looks like a nail, that can be a problem. So I think choosing the right procedure for the right person is probably the key in managing this problem. We usually do a couple things to figure that out. One is getting a size on a prostate. Some guys have had a recent CAT scan or MRI of their prostate, and we can get the size from that. Sometimes we do a transrectal ultrasound in the office to get a size on the prostate. And the other thing is taking a look inside with a scope. That's a flexible fiber optic camera. We do that in the office. We numb up the urethra before we do it. It's a little uncomfortable. It's not painful. I do that all day. To really get a sense of what the prostate looks like on the inside. Prostates can grow in different configurations. So with the combination of that ultrasound and the scope, really, I think fitting one of these procedures to a prostate is fairly straightforward. A lot of guys have multiple options, and then really it comes down to logistics and what risks, benefits, and what somebody wants to do individually. So I think that's all we've got. I'm happy to take questions. I imagine most of you have a urologist. Most urologists treat this problem. I should say probably all urologists treat this problem, but a lot of my partners treat this problem, and a lot of you may be patients of my partners. This is all fairly straightforward for us. So seeing a urologist, if you're dealing with this, is probably a good idea. Primary care doctors usually stop after Flomax doesn't work. Primary care doctors are great at managing the initial steps of this and the screening tests. We're the experts in it. So seeing a urologist is a great idea if this is a big problem for you.